Hello everyone and welcome to the final session of the Carer Knowledge Exchange Research Incubator for 2023, Making Connections, Exploring Carer Health and Wellbeing. Please note that this session is being recorded, and if you have any concerns with that, please take that action now. Thank you, and you're welcome to put any comments in the chat. Hello, and I'm Tish Cronon. I'm one of the senior managers at the Institute for Public Policy and Governance, and very proud partners with Carers New South Wales and the Department of Communities and Justice in bringing the Carer Knowledge Exchange to you. I'll start with the acknowledgement of country. I'd like to pay my respects to the traditional custodians of the land from which I am presenting today, the Gadigal people of the Eora Nation, and extend those respects to the lands where all of our panellists and participants are located today. I acknowledge their elders past and present and extend that respect to all Aboriginal people, including Aboriginal people joining us today. As many of you know, this year's Research Incubator has been delivered over 3 days, hosted by Carers New South Wales and the Institute for Public Policy and Governance at the University of Technology, Sydney. Over the last 3 days, these sessions have explored evidence-based carer health and wellbeing initiatives, service literacy and service access, connectedness and wellbeing, and this afternoon's session is an online workshop focused on measuring carer wellbeing in research and practice. The Carer Knowledge Exchange brings together researchers, policymakers, practitioners and carers to share their knowledge and learn from each other. It aims to improve outcomes for carers across Australia by connecting research to practice. This week's Research Incubator will delve deeper into the theme of health and wellbeing and further examine research practice and lived experience perspectives on this important topic. Today's session will be co-chaired by myself, Tish Cronon, and Prudence Granger, the Carer in Residence for the Carer Knowledge Exchange project. I'll just hand over to Prue for a brief personal introduction from her.
Hello, my name is Prudence and I am the Carer in Residence for the Carer Knowledge Exchange. My role in this project is to have my lived experience be at the forefront of the project, and it is something that I am very proud to bring into this project, as I feel carer-led experience is so important in the carer sphere of research. I'll hand you back to Tish.
Thanks very much, Prue. We're looking forward to having your experiences and your incredible knowledge filter into this session. So the purpose of today's session is to share and facilitate reflections on different methods and objectives for measuring and reporting on carer mental health and wellbeing, in order to produce a guide for researchers and practitioners and ensure that carer voices are represented within this. Firstly, we'll hear from 3 speakers. Dr. Xiaoping Lin, sorry about that, Xiaoping, Dr. Timothy Brody, and Associate Professor Sarah Whalen, who will speak about the use of the current tools and indexes we use to measure carer health and wellbeing. Following this, there will be a facilitated Q&A led by Prue, who you've just met, and who will explore how we prioritise carer wellbeing during research participation from a carer's perspective. Finally, we'll move into a series of small groups for a design thinking exercise around improving the use of these tools and indexes. You'll have the opportunity to engage with Zoom polls throughout the session, but the main engagement will come when you move into breakout rooms. I'll give you a very brief explanation of the activity that we're going to do. After you've listened to the speakers, and you have heard from the Q&A session with Prue, we'll go into randomly assigned groups. We're going to look at pain points and solutions. So it'll be really useful if during the speakers, if you want to jot down any notes for you to bring into that small group activity. There'll be a Carers New South Wales facilitator in each group who will record the thoughts from the group onto a template. And as I said, the things that we're going to focus on recording are the pain points for carers in the use of the tools, and then some of the solutions that we might be able to develop for those pain points. What would make it easier and safer for carers to participate in the use of the tools? And then we'll have some sharing afterwards as well. We'll conclude with a brief report back and then close with a 5-minute guided meditation led by Prue. So by way of context, before introducing our speakers, I'll just briefly highlight a few things around the current approaches to measuring carer health and wellbeing in research and practice. Currently, the mental health and wellbeing of carers is measured via a series of tools and indexes, such as the Personal Wellbeing Index, the Kessler Psychological Scale, Outcome Star, Caregiver Strain Index, and the Modified Caregiver Strain Index. Our presenters will discuss these tools in more detail, but generally they are used to gather data about the caring role, transitions in and out of the caring role, and changes that occur while caring. They ask questions around topics such as carers' quality of life, psychological distress, finances, social life, and physical health. However, there are limits to the data that can be collected using these tools, and indeed limits to what the data can tell us about carers' experiences more generally. Furthermore, cross-cultural understanding is often lacking in these generic tools, and there is no current consensus about which combination of tools is most effective. It has been determined that further research is needed into the advantages and disadvantages of these tools, and today we'll be reflecting on the use of these tools when attempting to measure carer mental health and wellbeing. With that as a bit of scene setting, I'm now going to hand over to Prue, who is going to introduce our 3 speakers. Thank you, Prue.
Thank you, Tish. So before I introduce our first speaker, what is about to launch on your screen is our first Zoom poll for your participation. So as that pops up, feel free to answer the questions as is appropriate for you. And I'd now like to introduce our first speaker, Dr. Xiaoping Lin. Dr. Lin is a research fellow at the Clinical Outcomes Data Reporting and Research Program in the Department of Epidemiology and Preventative Medicine at Monash University. She is passionate about providing optimal care to older Australians and their families, and her main research interests are mental health, dementia, and health service development and evaluation. Today, she'll be speaking about her use of Zarit Burden interview. Thank you, Dr. Lin.
So thank you so much. It's my great pleasure to share our experience about developed the carer reported measure for clinical quality registry, which I will explain a bit. So I'm from Monash University and I work at the Australian Dementia Network ADNET Registry. So before I start, I would like to acknowledge country. Monash University recognized that its Australian campus are located on the unceded lands of the people of the Kulin nations and pays respect to their elders, past and present. I will also acknowledge our amazing steering committee, which are chaired by Dr. Stephanie and Professor Henry Brotati. We have Steph is also our clinical lead, and Professor Susanna Ahan from Monash University is our clinical lead. Our operational team is based on Monash University, and we have a group of partners, and we are supported mainly by the NHMRC. So I just want to start my slide about some key statistics about dementia. So currently, more than 400,000 Australians were estimated to be living with dementia. So dementia is the second leading cause of death in Australia since 2013, up from number 4 in 2006. And it's the leading cause of death for women. It's also the second leading cause of burdens of disease in Australia last year, up from number 4 in 2018. and for women and for older Australia, it's the leading cause of burden of disease. So for these reasons, dementia has been identified as a priority domain for clinical quality registry development by the Australian Commission on Safety and Quality and Healthcare in 2016. Very important, carer plays a very important in supporting people living with dementia, particularly as the disease progress. So they have a significant impact on the patient outcomes such as quality of life and entry to residential aged care. And I think as you all understand, caring could also have a significant impact, both positive and negative, on the carer's own well-being. So for people with dementia, it was estimated between 137,000 and 354,000 unpaid carer providing care for people living with dementia. Very importantly, half of them are providing on average more than 60 hours of care weekly. So really it's a full-time caring job for many of them. So against this background, the ADNET registry has been established as a part of the broader ADNET initiative. So ADNET registry is one key component. We also have an ADNET memory clinic, which more focus on standardizing the practice across the different memory clinics. We also have the screening and trial. We are more focused on the research clinical trial end. So for our registry, the main aim is to collect and analyze data to monitor and enhance the quality and outcome of clinical care. And our secondary aim is to facilitate recruitment of participants into research. For us, we collect data from three sources. One is from our participating sites or participating clinician. So they will enter data, the contact detail, demographic, and clinical data at the time of a diagnosis of dementia or mild cognitive impairment. And after a patient is recruited into our registry, we then send out the participant and carer survey. So I want to highlight, we do survey both with the patient himself, also with their carer, if there is one identified. And we also intend to conduct data linkage with some of those administrative data sets to understand longer term outcome, such as hospitalization, medication, use of aged care. And this cycle is what we call a quality improved cycle of any clinical quality registry. This is really our core business. Everything starts from the middle top, the green circle, where the clinician enter the data for us. And then the data came to us, we do the recruitment activity, and then we send out a survey to participants and their carers. And then we put all this data together into two kinds of major use. One is we feed this data back to the contributing clinicians so they could understand how they are doing. And then at the same time, we will prepare public annual report. This is to inform policymakers and the public about the quality of care in this space. So currently we have 57 participating sites, nearly 2,700 participants, and around more than 1/4 of sites are located in regional area, and nearly half of our sites are actually private providers. So now I'm going to give a bit of information about how we develop our care measures. So we conduct some early work to look at what has been done in this space. We establish a survey working group, then we review relevant measures and develop a survey. We then conduct consumer consultation and then revise and put this survey into implementation. So I think you might know a lot of study. We will start with doing a scoping review to understand what has been done in this space. So what we find is there haven't been any care reporting measure used in the registry setting. In many research, a lot of time these measures were administered face-to-face. And we also conduct a qualitative study with carers to understand what they think is important to them for a register to collect. They talk about it's important to understand their outcome, but they also want to have questions about their experience of the service. So what we find as from our scoping review is actually currently there hasn't been any carer report measure, and most of the measures were often administered face-to-face. And I think for our registry, people, the carer want us to include both outcome and experience measure. One of the issues that is often overlooked in research is the issue about copyright and license fee, because a lot of those measures actually is licensed and you actually need to pay a fee if you are using and funded research. So then we established a survey working group to report this back and to guide our survey developed work. And this survey group include people with lived experience, carer, big bodies, clinicians, and researchers. We review what are some possible measures we could use. And one is the aspect is of those important outcome measures, and also some of additional ones recommended by our working group members. We're also looking at a number of experience measures which we did not looking at during our scoping review, and a lot of them actually has been widely used. For example, the Australian Hospital Patient Experience Question Set. In New South Wales, they also have the experience of service survey, and I know they also have been a mental health carer experience survey. So we review all these possible measures, and when we're looking at that, we consider what other domains have been covered. And I think for us, we only want a very short, brief survey. How people respond this, is it a 3-point or 4-point or 5-point like scales? How this survey could be administered? Is there any license fee involved? And also, has this measure been developed as a dementia specific versus the general population? And for people with dementia, we do need to consider the issue about the user-friendly format. So based on that, our survey working group have 5 rounds of experts consensus to decide what we want to include in our survey. So we're looking at a domain, and we want to include domains that are most commonly included. We want it to restrict to 2 pages. We want to include both outcome and experience measures. And I think for clinical quality ratio, very different to many research, we want to directly inform clinical care. So for us, we want to focus on the experience measures. And our focus has been looking at respect, involvement in decision-making, information and support, and overall experience of the service. Importantly, we also want our survey to provide an opportunity for people to know about the key support organization in this domain. So with this into consideration, this is our draft survey. You could see we start with a number of 8 questions about the experience of the service. We have an open-ended question people could put their comments on. Then we end with some question about health and well-being, about some basic demographic. And we end with information of the National Dementia Hotline. So with this, then we conduct consultation with the consumers, and it's facilitated by Dementia Australia, with participants recruited from the Dementia Advocates Program. And we try to include people from diverse backgrounds, including metro and regional area, people from different cultural backgrounds of regional people. So for carer, we conduct focus groups and individual interview. And for people with dementia, we do individual interview. So this is just some of the photo when we do this Zoom focus group with carers. So overall, the consumer feel they like the format of our survey. And I think they have a comments about the term. I think in research we use quality of life a lot, and they feel it's very broad. They suggest using the word well-being, which is more acceptable, easy for understanding. They suggest we start with the outcome question to the start of the survey, and they also suggest the use of an online version if possible. So we take this recommendation on board, and this is our updated survey. Now we have the health and well-being question, and then the demographic question. Then we'll finish with our experience, and at the end, the open-ended. And again, we keep the information about the dementia helpline. So we implement the survey in February 2021. And in the 2 years' time, our response rate is actually quite good. It's around half of the carer returned the survey. For participants, slightly higher, 52%. And I think very important for our, as a clinical registry, very important for us to share this data with our participating sites so they can use it for their own data improvement initiative. We share it in two ways. First, we have an online database where they have real-time aggregate data is de-identified. They will be able to see how their site performing compared to other sites. So for them to have access to this online real-time data. We also send out my annual benchmark site reports, where they, again, we benchmark their data to other sites, and we put patient and carer together so they could see there any difference between the response from patient and carer. So for them, they will be able to identify what they are doing well and what not so well at the participating site level. So for us, we are looking a few things for our registry in terms of the survey. We are hoping to develop the follow-up surveys, but there are a number of practical issues we need to consider. How frequent should we run this? There definitely will be change of care in some situations, how we manage this. And I think with a follow-up survey, one tricky thing is carer will be used different type of service. How we cover this while still keep the survey short. We are developing electronic version of the survey, and we are exploring strategies to maximize survey response. We are happy with what it is, but we are hoping to further increase our response rates. And we are looking ways where we could use this survey data more closely with the participating site to drive their local quality improvement initiative. So currently, we are the only dementia clinical registry which collects care reporting measure. And this data has been highly appreciated by our participating site. They feel it's very helpful for them to understand patient and carers' experience of service. So this is our team based at Monash University. Thank you so much.
Thank you so much, Dr. Lin, for sharing about the Australia Dementia Network. It's wonderful to hear that there are lived experience being involved in producing your survey, and that those results are being shared with the participating sites for improvement in carer wellbeing. Next, we have Dr. Timothy Brodie. Dr. Brodie is a senior lecturer based in the Centre for Social Research in Health at the University of New South Wales. The Centre for Social Research in Health undertakes and promotes research in health that informs and strengthens knowledge, policy, and practice. His recent work engages with stigmatised communities in the Australian health system, and today he'll be speaking about the use of general population measures such as the Personal Wellbeing Index and the Kessler Psychological Distress Scale in the context of caring.
Thank you. And yeah, thanks for the invitation to be here today. I'd like to just start by acknowledging that I'm coming to you from unceded Darug land, paying my respects to elders past, present and emerging, and also extending that to any Aboriginal or Torres Strait Islander people who are joining us today. So as we just heard, about my background. I just want to give a little bit extra detail around my background and what I'll be talking about today, mainly because it's a slightly different style of presentation to what I'm used to. So I'm hoping you can bear with me in that respect. I'm currently working at the Centre for Social Research in Health, and as you've just heard, focusing on groups that experience a lot of stigma and discrimination. And obviously, stigma and discrimination has a lot of links to wellbeing. So, these are the kinds of measures that I will get to work with on a very regular basis. The groups that we work with tend to be groups affected by bloodborne viruses, so slightly different from a carer context, but also some overlaps because carers are heavily involved in the care of people affected by bloodborne viruses and anyone involved in the healthcare system. But when I talk about these particular scales today, I'm also going to be reflecting a bit on my experience from a previous job when I used to work at Carers New South Wales. So part of my role there was revolved around the carer survey. So I'll be talking about the measures of wellbeing that were used in a couple of rounds of those surveys, and then also reflect on how I've used those same measures in different projects since. So basically looking at how one particular measure can be used at a general population level and can also be used in specific contexts as well. So just as a little bit of background and flagging why measuring wellbeing is important, and particularly looking at the fact that it's important for all people. So I don't want to go into too much detail here, but basically when we're talking about wellbeing, I think a lot of people just intuitively know that it's a really important concept, and it's something that really does matter to everyone, and specifically for for more targeted groups as well. There are a whole range of health, employment, relationship, and economic benefits that are related to wellbeing, and there's a stack of research that backs that up, as well as anecdotal evidence. It just makes a lot of sense that those things will all be related. At a strategic level, governments are very invested in the well-being of populations. One key document that I've just noted here on this slide is the National Preventive Health Strategy that specifically says it aims to improve the health and well-being of all Australians. So again, it's just highlighting that idea that well-being is important for all people. But in saying that, there are specific groups that are likely to face specific issues related to their wellbeing. So as much as it's important for all individuals, families and communities, individual groups have specific considerations that we need to take into account. And it's important to understand those differences, particularly in terms of then moving on to how we might address those. And so one of those groups is obviously carers. Some of the work I've been doing recently also focuses on some other stigmatized groups across the country. So I'll touch a little bit on that, but also, obviously today we want to focus on carers as a specific group and how these measures of wellbeing that are utilised at a general population level can really highlight some of the specific issues that carers might face. So rather than go into showing a whole lot of different results about carer wellbeing, today, I'm really going to focus specifically talking about the measures, how they're used, and sort of some of my own reflections on how they're used in research, what it can show us, and kind of reflecting on that experience as opposed to looking at a specific project per se. So the first one I wanted to talk about is the Kessler Psychological Distress Scale, or K10 as it's more commonly known. So this is a very, very widely used scale internationally across a huge range of different contexts. This is a scale of non-specific psychological distress, which sounds very technical, but basically is just saying that this is a very broad measure. So we're looking at psychological distress, and it's not specifically focused on any given context. Because of that broad focus, it can be used in a range of different ways. So for example, one of the ways it can be used is in a clinical context. In a counselling or psychology type setting, this brief scale of 10 items can be used basically as a bit of a flag to see how someone is functioning in terms of their distress, particularly in the very short term. It's focused on the last 4-week period, so you're really looking at how distressed someone might be in the here and now. And just getting that as a bit of a baseline measure in a clinical setting, or as a little bit of a flag, can be very useful in that context. As we're talking about today, it can be very useful in a research setting as well, because it's a short scale, because it's numbers on a page, we can generate scores and look at things in a quantitative, do all kinds of mathematical models to look at what factors are associated with psychological distress. What does psychological distress predict? Which groups experience more than others? We can really look at developing an evidence base around psychological distress of different community groups by using this one particular measure. And because it can be self-administered, so it can be put on a survey, someone can tick all the boxes and hand it in, it can make it quite useful, very easy to use. In a clinical setting, it can also be administered by a clinician where they talk people through the questions and support them through that. But in a research context, it does tend to be used as a self-administered tool. Also, just wanted to note that there are shorter versions of this scale available. So even though 10 items is generally considered quite short in terms of a scale for research purposes, if the 10 items seems too long and some of them might seem like there's a bit of overlap or a little bit of repetition, there are shorter versions have been developed where they use either 5 or 6 of the items. And depending on the specific research question, what you're trying to get out of the work, sometimes using that shorter scale can be just as helpful. You can get a little bit more detail from a longer version, and it can change some of the scoring and how things might be categorized. But again, it just comes down to that idea of what are we trying to measure specifically, and if a shorter measure is going to work, then asking 5 questions I think is always going to be preferable to asking 10 if it's going to get you the same outcome. So in terms of using this scale, like I said, there are 10 items. People rate their response on a scale of 1 to 5 to give a score out of 50. Final scores range from 10 to 50, and then those can be categorized. So in terms of how we use the data, that can be used as the scale score, the individual number, or can be categorized. And because this is so widely used, different groups have come up with different cutoff levels for how they want to categorize levels of psychological distress. So for example, some groups look at breaking things down into 4 specific groups of low, medium, high, or very high psychological distress. So you can look at things at a more aggregate level, looking at those individual groups rather than focusing on, well, what does a score of 22 out of 50 actually mean? Particularly with the shorter versions of the scale, it can be then broken down into other cutoff points, such as how likely someone is to have an underlying serious mental illness. So whatever that cutoff score might be, if you score below that, then it's unlikely that you have an underlying serious mental illness. And if you're over that score, then the likelihood is significantly higher. And so from a clinical point of view, there's obviously a lot of value in that. Now, fortunately, this is one of the scales that's publicly available. You type it into Google and everything pops up. So I feel much more free to be able to share this with you today and just give you an example of these are the sorts of questions involved in a scale of psychological distress like this. So as I mentioned before, it's talking about in the last 4 weeks, how often did you feel tired for no good reason, nervous, so nervous that nothing could calm you down, and so on. You've got terms like hopeless, depressed, worthless in there. So one thing that I do want to flag is that one of the things that stands out in using a scale like this is it can be quite confronting and triggering, particularly for someone who is distressed. So see these words pop up in a survey can be quite difficult, particularly when it's self-administered. And that's one of the things we need to take into consideration. Now, I said that I was going to focus more on the how the tool is used. So as I mentioned before, we can categorize people based on their responses into those categories of low through to very high levels of distress. And it enables us to make comparisons across various groups. This is a scale that we used in the carer survey back when I was working at Carers New South Wales. So I have just on the next slide taken a screenshot from one of the previous reports. If you want more detail, I encourage you to look at the reports from the carer survey that are still available online. But you can see some of the comparisons we've made here, looking at responses over time from the 2014 carer survey to the 2016 carer survey, and then also comparing that with data collected by the Australian Bureau of Statistics, looking at carers and also non-carers. So in here, what we can see is because this is a widely used scale and because it can be used across different contexts, we're able to compare levels of distress reported by carers in each of our samples that we collected in the carer survey compared to a different sample through the Australian Bureau of Statistics. I won't go into too much detail here, but really what I wanted to show is that this enables a really clear comparison, and we can highlight where the differences are between different groups, whether it's carers versus non-carers, or whether it's between different cohorts of carers or other population groups. Also wanted to touch on the Personal Wellbeing Index. So this is a subjective measure of wellbeing with 7 specific items that reflect quality of life. It's also important to note that even though it's only 7 items, this is a very theoretically driven instrument. So a lot of work went into understanding the theory behind wellbeing, what quality of life looks like, what domains would reflect that more broadly, and all of this huge amount of work eventually got reduced down to 7 individual items to reflect people's satisfaction with life as a measure of their subjective wellbeing. It's been validated with adults and children and people with intellectual or cognitive disability, which basically means a lot of work has gone into showing we know that it's measuring what we think it's actually measuring, which gives us a lot of confidence in being able to use it at a broad population level and also within specific population groups as well. Using this scale gives you a total score out of 100, with higher scores representing higher levels of wellbeing. But it's also particularly useful because each of the individual domains can be looked at independently. So here are the 7 domains listed on this screen, and it's basically asking people how satisfied they are with each of these: standard of living, health, what you're achieving in life, personal relationships, how safe you feel, being part of your community, and future security. So as well as producing that overall measure of well-being, you can look at each of these individually. And similarly to what I showed before, where you can make comparisons between different population groups, if you can see overall, okay, one group is reporting significantly lower well-being than others, we can then delve into things a little bit deeper. What aspects of well-being are driving that? This well-being index it has been particularly well publicised in carer research since 2007, when the group who use the scale on a regular basis did a specific report on carers, and they found at that time that across every population group they'd ever looked at, carers reported the lowest subjective well-being compared to anyone else they'd ever studied. And that's not to say that there weren't worse groups out there, but just at that time, that was the lowest reported well-being they'd found. And that has been a really useful advocacy tool since 2007, with a lot of research reflecting on very similar issues ever since. So just in the last couple of minutes, I just wanted to put a couple of final reflections about using tools like these, specifically in carer research. There are obviously some pros and cons to any sort of survey instrument. In terms of pros, the fact that these are very widely used and well-developed scales means that there are standardized scoring methods. You get your data in, you're told how to score it, and you're told how to interpret it and what the numbers mean, which is really, really helpful in terms of understanding the implications of the research. There's normative data available for both of these scales, which means we can compare what we find in our samples to what you'd expect to find in the general population. And when you see differences, we can talk about what those mean. There are also translations into lots of different languages, which can be particularly helpful for culturally and linguistically diverse participants. The cons are there's a lack of context. So because they're so general, we can't really delve into the detail of what's driving these overall findings. And as I mentioned before, they're potentially triggering. Even the Personal Wellbeing Index, which doesn't necessarily seem as triggering at first. I was having a conversation with some of the staff from Carers New South Wales earlier this week, and we all kind of agreed, well, yeah, it's not triggering until it is. When you're asked how satisfied you are with your quality of life, if you're not satisfied, that can still bring up some really triggering issues. One of the things that I have found in doing a lot of work around these sorts of measures is that including multiple measures can really help with research analysis and understanding different factors, different facets of well-being. So these are just 2 examples, but having both of them looking at well-being from a different angle can be really helpful in terms of understanding a lot more detail of the population group that you're looking at. And there are also implications beyond research, things like self-reflection. I've recently myself participated in a research project as a participant, and in filling out the K10 as part of that, all of a sudden I found myself reflecting on, how is my psychological distress going? And I could see how it might be triggering, but equally at the time, because I was aware of how the scale functioned and knowing where the cutoffs were between low psychological distress into higher levels, I could really reflect on how am I going this week. And, I think there is an added benefit and potentially a therapeutic benefit in being able to reflect on things through a process like this, as well as there being the potential for triggering. So it is a very delicate balance. And I think that just leads into my final point, that community consultation is really vital. We can't just put these sorts of measures into surveys and expect it will all be okay. We need to communicate with the communities that we're working with in the first place and really get their feedback on, is this going to be triggering? Is this going to be a safe measure? What can we put in place to make sure that we can get this really useful data without putting people in harm's way? It's not necessarily a straightforward answer, but we need to really work together with community representatives and advocates to make sure that we do get the important data and work for the best interests of our participants. So I'll leave it at that for now, but happy to take questions further on. Thank you.
Thank you so much, Dr. Brodie, for your very candid and informative explanation of these two measures for carer wellbeing. I couldn't agree with you more that we really do need to take into consideration the impact that this data collection can have on the groups that we are working with. As important as the data is, that impact needs to be measured. And I think we'll be talking about that a little later on. Next, we have our final speaker, Associate Professor Sarah Wayland. Sarah is the Associate Professor and Discipline Lead Social Work in the School of Health at the University of New England. Dr. Wayland is currently involved in several projects examining workforce responses to suicide attempting, trauma exposure, and the needs of carers, including evaluation of mental health services, with a focus on including the voices of those with lived experience to inform policy, research, and practice developments. Today, she'll be speaking about her use of the Caregiver Strain Index. Thank you, Sarah.
Thanks, Prue. It's really lovely to be here, and I think it's quite fortuitous that we had Xiaoping first and then Timothy, because I feel like what I prepared to talk about segues really nicely. So it's always very convenient when that happens. So I'm really proud to be here today. I am zooming in from Darug and Ku-ring-gai land in the northwest of Sydney. I am a social worker by trade, and I also have lived experience of caring. What I'm going to talk about today is not necessarily the hard and fast data of measuring and scales, but I guess my research and my lived experience reflections of working in this space for quite some time. As Prue said when she introduced me, I've been working in mental health evaluations for the last 12 years. I'm a grief and trauma researcher, and I have a special interest in caring and workforce development. What I've learnt from working and I guess living and existing in this space is that we always need to be understanding as researchers that we don't exist in a vacuum, that we don't make decisions about collecting data, I never call it data collection, but that we're gathering or co-constructing the narratives of people's lives, whether that be through a crude scale or whether that be through some qualitative engagement. So part of the reflections that I wanted to centre on today was a research project that I've been working on over the last 5 years with Professor Miff Maple at the University of New England. We also work in partnership with Everymind. We've partnered with Sane Australia, and we've also partnered with carers in the community with lived experience of providing support as a carer in terms of providing support around mental health needs and providing support in relation to suicide attempting. A couple of weeks ago, I was really honoured to be invited to write very quickly, 2 hours notice, for the conversation in response to a Q&A episode on ABC that profiled the very complex and distressing lived experience of being a carer with someone who lives with suicide attempting. It reminded me that irrespective of the research work that we do, the pamphlets that we make, the websites that we design, that often what happens out there in the community is that carers are viewed as providing the in-between space, when it's often the most important space of providing support to someone that they care about. I think what I've learnt in terms of attempting to use scales and better understand quantitative as well as qualitative measures is that we have to view the carer as a whole, and understanding that not all scales and not all interviews will actually reflect on the lived experience of somebody's lives. One of the pieces of work that we also did over the last few years was look at the intersections of caring. And I know that whoever is here in the webinar listening who is a carer, that I'm not telling you things that you don't know. But I think that what we've learnt is that looking at those intersections within caring, and this might be through disability, traumatic injury, mental health, suicide prevention, dementia, that we need to have accurate portrayals of those intersections of caring. And what we're attempting to capture is not the whole experience, but different component parts that are impacted by different stresses. We do this a lot of the time in our qualitative work that we do, when we engage face-to-face with people and talk to them about the stories of their lives. We hear from them in focus groups, and we get that sense of the descriptions and the nuance and the relationships of how carers talk about the before and the now, about who they were in terms of the identity or the relationship with the person that they care for, and the ambiguities when that changes over time. I think we always need to recognise that there is no scale that will actually accurately identify what that experience is about, as well as sometimes thinking about a standardised definition of what a carer actually is. I think what we've uncovered from our research very much in the mental health and the suicide prevention space is that the experience of care is poorly understood from service delivery perspectives, that it needs to be better understood as a continuum or a spectrum over time around crisis, intermittent, situational, practical, emotional tasks that are required in caring. That if you talk about the carer experience, you have to think about all of those octopus legs that sit underneath it. That we need to take into account the historical flexions of what it means to be a carer. That we need to think about that we better understand some aspects of care than others. And there are certain aspects of caring, like that episode on Q&A, that we just don't want to engage with. So part of the work that we always do before deciding, well, what outcome measures or what scales do we need to utilise to better understand this experience is really checking in about what our experience of caring is. Understanding the role of informal carers, thinking about willingness and sometimes reticence to care for vulnerable family members. What it means from a workload perspective in terms of providing care, and what are the ways in which policy and legislation reflect on that caring experience. I think all of that pre-work has to be done in the research space before you decide what the method is going to be. I think sometimes it's very easy when we're writing research papers to say we did this and then we did this and then we did this and Shazam, here's the outcome and this is what we're suggesting. But there's a lot of pre-work that needs to happen, both in terms of understanding why we're researching, but also understanding the lived experience of being research participants. And I think Timothy really beautifully articulated that, about understanding that when we put in our ethics applications and we say we're going to ask carers these questions, we're often asked to identify what will be potentially distressing. But it's an inexact science. What will be distressing to one person will be not distressing to another. We can predict what the responses might be, but we also need to ask ourselves as researchers, what's the value of asking that question in the first place? And are we collecting data that we can do something with? I think I've often thought about, that metaphor that there's blurred lines in caring, that you engage in being the family member, the carer, the case manager, the financial guardian, the person that just wants to have a laugh with somebody all at the same time. And in research, we also need to understand those ambiguities and develop our research scales in relation to that. So that's probably a very long introduction in terms of talking about, well, what measures do I use in the research that I do? I'm very much a proponent of mixed method studies. I think that utilising quantitative scales or collecting quantitative data will tell you one aspect of the story, combining that with the qualitative engagement of building rapport and really listening and centering a person's story If you combine those two aspects together, you get a really beautiful overview and a unique insight into what is happening for a carer. But it's only ever a point in time reflection. You can be having a really great day as a carer and do that work. You can have a really rubbish day and do that work. And it's going to impact the way that you engage with the research. I always think of time as pre-pandemic, post-ish kind of sort of pandemic. At a time pre-pandemic, we were very lucky to be involved in a study with Sane Australia around better support for carers of people with complex mental health conditions. We utilised that very same mixed methods approach in terms of collecting information from people to then be able to take that, sit with it, reflect on it, dilute it, understand what the gaps were, and then take those gaps to the qualitative research space. This was 2018 when we heard from 834 people who wanted to talk about their lived experience of caring for someone with suicide attempt behaviours. From a scales perspective, we looked at caregiver burden scale, we looked at suicide bereavement, we looked at suicide and stigma, and we also, like Timothy talked about, used the K10 distress scale. Our goal of doing that was to try and build a picture around the fact that there are aspects of caring we needed to understand, so that's why we used the caregiver burden scale. We wanted to understand the carer as an individual, so we used the K10 scale. But we also wanted to talk about the unique overlay in this space around suicide, exposure to suicide, and the impact of suicide bereavement. We wanted to understand what the unique stress reactions were of carers, but also recognise that any postvention work that we can do is prevention work. So supporting carers who are bereaved by suicide is individually supporting that person who might be at further risk of suicide. We then went on to think about the ways in which we could take what we learnt from the data and apply that to our qualitative analysis. So almost designing a bit of a scale in itself of thinking about, well, what are the core questions we want to ask? The core questions we asked 45 people from that 834 participants, and we spoke to them over a number of years, and it resulted in a website called You Are Not Alone, which is hosted via Sane Australia. Really recognise the fact that, you know what, the quantitative measures were sometimes different than what we learnt in the qualitative analysis. The stories of people's lives were far more detailed, a lot more light and shade than what we saw in the quantitative data. We recognised the capacity to be able to talk to people in those spaces qualitatively, that we could unpack the stigma surrounding even the term carer burden. Carer burden scale suggests that burden exists and we want to understand it. When we speak qualitatively to people, they say, I don't necessarily engage with the idea that this carer activity is a burden for me, but it does have impacts on my well-being. Sometimes there are just not the right scales to use all of the time. And if we all had more than 24 hours a day, we could design more innovative scales to be able to collect the data that is useful for continuing to fund services and better understand lived experience. But what we did see from utilising the carer burden scale in this opportunity, and we have an open access paper in relation to this study that I'm happy to share later, is that we saw that the burden was related to the ambiguity of the situation. And most of the time, the distress was not just about the presentation of the person and the ways in which care needed to be offered, but primarily that distress was focused on the lack of support from health services and how carers were the space in between discharge and the first appointment once you get home, the space between this appointment and the next appointment, the space between kind of midnight and 7 a.m, the space between not understanding that carers have lived experience, but it's not an add-on to the person who requires care, but that it's a unique form of lived experience on their own. So I think in reflecting and kind of bringing this together for the end of the conversation today before we move into groups is thinking, you know, we'd spend a lot of time in our research group at UNE and with many of the collaborators that we work with, is asking the question of, well, what should we be messaging? What should we be measuring? We should be messaging too, but what should we be measuring? So reflecting on the voices of caring as distinct from the voices of lived experience, making sure that we honour and corral those spaces so that we can measure that impact. Is that we need to understand the role of carers in families and understand that burdens of care are important ways of measuring, but they're not necessarily the terms that carers use themselves. That we also need to measure ongoing the health economic costs associated with the activities of caring, because carers provide the bridge for the health system in terms of the spaces between those appointments and those access to care. I think in being uniquely invited into the space of care as running think tanks, focus groups, whatever fancy terms you want to call it, for people to come together and talk, is that there's sometimes a little bit of a disconnect between what the scales tell us and what the person in front of us says. It doesn't mean that one is right and one is wrong, but it does demonstrate the importance of seeing carers holistically, but also understanding that they need to be provided with the right opportunities and ways in which they can share data with us that is meaningful for people that come in the future. So I hope that's helpful, and I'm happy to talk in the breakout rooms as well if people have any further questions. So thanks for your time.
Thank you so much, Sarah. A very evocative presentation. There was a few things I really took away from what you said. One particular thing was right at the beginning when you said, are we collecting data that we can do something with, really evaluating what data you're collecting and the purpose for it. And seeing carers holistically, I think that is something we can all agree is super important in this work that we are doing. Now to the Q&A section of today's workshop. Thank you so much, Timothy, Sarah, and Xiao Ping for involving yourself in this Q&A. I would like to lead this from a carer's perspective and as somebody who has participated in research. And I know in some realms of research, there has been different markers of when I have felt supported or that my well-being has been looked after in these sorts of settings. So I'm really, really curious to hear from you in a more informal setting. And so these indexes are designed to measure carers' mental health and well-being. But what measures or avenues of support do you implement or make available to ensure that carers' well-being is prioritized throughout your research processes?
Who's going to be the lucky person to start?
I think you've just volunteered yourself, Sarah.
I always do that. It's a really important question. And I think that sometimes when we have to work very hard in the research environment in quick turnaround times, is that sometimes we actually don't get the opportunity to pause and reflect on this question all of the time. That wellbeing is not about providing a phone number to Carers New South Wales or Lifeline at the end of an interview, that it's about all of the ways in which we engage and intervene with people. So I think from a wellbeing perspective, it's very much about understanding right at the beginning who's on the research team, what their expertise is in terms of the ways in which they bring something to the table around the research methods, but also are they a practitioner? Do they have lived experience? If we don't have somebody on the team, we always make a commitment to make sure that we don't just add somebody with lived experience at the point where we have to report against who's on the advisory team or who's on the research team, about making sure that lived experience is embedded in all aspects of research, I think is integral, and that people with lived experience on research projects need to be paid. We don't give out gift cards to people because you can't eat a gift card, is my thought. So taking that right from the beginning. But I also think it's about preparedness. There is nothing worse than seeing somebody scramble to fill in a survey or a scale that they didn't know they had to do beforehand. So letting people know what is actually being asked of them, the time, the emotional time, the labour, the technology awareness, and also providing space for people to let you know if they're not comfortable with reading and writing or engaging, they don't have an iPhone or they don't know how to download a QR code. You know, we keep coming up with these kind of fancy ways of doing things, but time and respect are integral to wellbeing. And the last thing that I have found has been really useful over the last few years is not expecting people to give me their reflections straight off the bat. So I make sure that before I bring people together, if it's a focus group or a think tank or a forum, that a week before I send them an overview with really clear details: where you're going, where you're parking, is there coffee and tea, is there disability access. But these are the sorts of things we're going to talk about, and these are the sorts of things that you might like to prepare, because not all of us can talk underwater. And we need to make sure that we don't make people feel marginalised when they do come to share or do come to fill in forms or scales or whatever it means, that they know what's ahead of them, no surprises. So I think that all of those kind of practical parts really impact on wellbeing.
Those are really, really great reflections. I do appreciate that element of transparency. I know I've been in situations where it hasn't been completely revealed to me exactly what it is I'm participating in. And also that element of return on time investment can sometimes get a little gray, and the gift card analogy, can't eat a gift card, love that. Great reflection. Does anyone else want to share? Yeah, Xiaoping?
Yeah, hello, thank you so much. And I think that it's also, I think probably for a researcher, for us, it's really how we ensure the data we collected been used effectively. And I think that, you know, the information sharing and how you use this to inform the practice. And I think that it's very important for us to kind of ensure that, you know, I know a lot of research and how we give back to participants, letting them know. So I think sometimes we haven't done this well enough, but I think that it's very important for us to acknowledge the contribution of the carer and what they help us in terms of, you know, improve the understanding, improve the quality of care. And I think that really, you know, appreciation of the result is not just we collect the data for data collection's purpose, but it's really be used. So I think that it's very important to show how this data are being used to inform practice. That is, I think that probably from cancer particular with a registry point of view, we are closely linked to the kinds of the implementation to ensure it's used to inform practice.
Amazing. I think, yeah, and it goes back to what Sarah was saying in her presentation, to make sure the data that's being collected is useful. Tim, do you have anything to share?
Yeah, I mean, I agree with all points so far. I think particularly just wanted to, I suppose, leverage off what Sarah was saying around the expectations, and particularly because research can take so many different forms. So, you know, if you're talking about doing a one-on-one interview with someone, or, you know, a Zoom interview or a focus group in person, those are all very different contexts and obviously have very different considerations. The bulk of the work I do is survey-based, so I actually don't see the people, the participants that I'm working with face to face. You know, I send surveys out. If they're online, you know, I advertise these links, and somehow, you know, we get responses through Qualtrics, and you know there's another person on the end, but you don't have that direct contact. So how you address well-being is very different in that kind of context. So I think it's very important to say, you know, these are the things we're going to be asking people about. You know, putting sources of support up there as kind of, I agree with what Sarah said. You know, it's not just, oh, here's the Lifeline number and away you go, you've ticked that box, you're all okay. But it is important to have those things. Also, depending on what the whole survey is about, if wellbeing is just part of it, and say, okay, the next couple of questions are about, this is what it's going to be about, feel free to not answer them and just skip over, giving that kind of an option. And I think one example from my recent work, not specifically focused on carers, but I think the general premise still holds for any group we're working with, is we were running a survey of people who inject drugs, and it was all around stigma and discrimination. So we had some of these wellbeing measures. We also had stigma measures. So everything was, the project was focused on a very, very negative thing, and we needed to ask really hairy questions because of the nature of the project. The way we recruited was through peer-based organisations, and so they were handing out paper-based surveys. People were completing them and then handing them back. And a lot of the reflection we got was, for items on the K10, well, I didn't feel worthless until you asked me about it. And now I feel like rubbish. So thanks a lot for that. But because we had worked very closely with community organisations, they were there on the spot. And so when people were triggered, there was someone right there who could kind of manage that. And then moving on from that, when we've gone to do the next round of surveys, we've worked closely with them to say, okay, we know that happened a bit last time. Tell us how we can do it better. Do we need to just scrap those questions? How can we improve the processes to make sure that participants aren't going to be triggered and aren't going to have a really negative experience? And so we did end up adapting certain aspects of the questionnaire for the next time around, and the feedback was far more positive. So, that ongoing relationship with the communities you're working with, the advocacy groups and the support groups is so important. Having them on board just means, number one, it works better from our point of view, just in terms of the raw research data, but also the overall outcomes, of the project isn't just about getting the data, it's about improving quality of life and everything around that. So those kinds of conversations and partnerships are just so important, particularly when you're talking about these types of issues, and particularly with groups who might feel stigmatized or might have, might be really triggered by some of the questions that we do ask in those sorts of surveys.
Thank you, Tim. I think that sounds really proactive to be continuing to work and reflect on how this process lands. Sarah, you have your hand raised.
I do. I'm trying to be appropriate. I was just thinking what Timothy said about, I think it's really great to recognise the visceral responses that people have to the questions that we ask, and amending those where appropriate and thinking about it. But I also think sometimes, and I'm going to make sure I say this the right way, distress is not a dirty word. I think we all live very messy, complicated lives, and that's the nature of being a human being. And I feel like the use of the term trigger or minimizing distress sometimes negates the opportunity for someone to tell the true story of what's going on for them. So if we kind of dilute our questions so that we don't upset people, the intention of the question is never to upset somebody, to kind of like get them to tell you, the really detailed stuff. But it recognizes that living in that carer space means that there will be distressing things. And I think it's important to safely talk about those, because if we remove the questions that we ask, then we remove the data that would be really helpful for shaping services. So I think that I often preface my questions to people saying, sometimes people, this question might make people cry, or it makes them reflect, or sometimes they just need a bit of time to think about it. But overwhelmingly, the feedback that we get that you need to embed as a researcher, ask the participant what was the experience of taking part in the study, is most times people will say, you never asked me something that I hadn't ever considered before. You hadn't asked me anything new. And yes, it was distressing to revisit and talk about, but that doesn't mean it shouldn't be spoken about. So it's always that's one of the core challenges of being a researcher, is that you have to engage in the messy space. But the messy space yields really beautiful outcomes if you promise to make sure that you translate that data to everyone that needs to hear it in an ethical way. So, yeah. And like Rachel said, it's not the carer's job to make you comfortable. If there's an awkward silence, or someone says, I hate that word, or don't say that, it's a reminder to pull yourself back and reconsider your research skills, not I'll take that question out because that upset somebody. Sometimes as the researcher, we need to be doing more work on ourselves and how we deliver it too.
This really wonderfully segues into my next question, actually. how do you ensure that research is genuinely co-designed with carer participants rather than tokenistic? So what are your protocols for care responses that may not align or disagree with the original focus of the research project?
You use and make sure that you understand all the co-words meaningfully. What is authentic co-creation, co-production, co-design, co-ideation in the first stage, and then co-create those outcomes together. And making sure that you don't just invite people to the table because it's going to value add the research project, but it has to value add the person who's coming to the table too. And I think that comes down to appropriate pay and better recognition of lived experience as a core research need. I'm just about to have someone arrive at my house who just finished her PhD on co-creation of knowledge. She identified all of the co's, and it made her a little bit wonky in trying to understand it all. But I think that it's an emerging space. We need to do better, but we're learning as we're going as well. So I think reflecting and making sure that you appropriately involve people, not tokenistically involve people, is probably the thing that I try and do the most.
Yeah, I think it's, this question really comes from personal experience in these research settings where perhaps what I have contributed has maybe gone a little off script, and I've been unceremoniously pointed back to where they want to go, and felt as if sometimes if I'm not necessarily saying what agrees with the outcome they're looking for, that it isn't appreciated. So it's really wonderful to hear that there is this co-design being focused on, so that carers can really be heard. Xiaoping, I saw your hand go up just before Tim's.
And thank you. And I think that for researcher, really, it's important for us to, your methods, and it's flexible. You are able to adapt and change according to the comments from the carers. And I think that for example, for our registry, when we start, like, we kind of very focus those question about outcomes. But through our consultation with the carers, it appears that experience is very important. And for us, you have the scope to be able to incorporate, to change your scope, to focus on those things that matter most to the carers. So I think that it's also, don't start with a very rigid focus, broad and kind of more focused on what it really matters, and you're able to adjust and change, and then to align with what really the carer wants. And so this will also increase the value of your research, because it's something really of the practical and to the carers.
Thank you. Tim.
Nearly forgot to unmute myself. I think I'd be better at this by now. Yeah, look, just two things that I wanted to add on that. I think, firstly, just highlighting some of the difficulties around, that whole idea about when something kind of comes off focus. One of the challenges, and I think it's something that as researchers we need to get better at, is around adapting to that, and particularly in a funding environment where, we need to get funding to be able to do research. So you have to convince the people with the money that this is an important project and this is why. So then when you get into that and things start to deviate from that, you kind of go, oh, but we've been funded to do this, and how are the funding bodies going to respond to it? So there needs to be a certain adaptability and flexibility in that, where yes, you need to meet your funding requirements, but also anything that comes through a consultation process or through the data collection as well that sort of starts to deviate from that is still important, potentially even more important than what you sought to achieve in the first place. So there kind of is that balance that you've got to get right. And I think that there is a bit of there's a skill in being able to navigate both sides of those and give appropriate attention to, the core research aims of what you're doing in a particular project, but also hearing well, what data are we being fed? Because if that's the stuff that we're hearing from people, then obviously that's important, and we need to respect that, and we need to give that the time and place. And the other point I just wanted to raise is that if you're talking about, you know, how to effectively do co-design, and I agree that this is really an emerging area where, you know, people are learning all the time how this works. To set out at the beginning of a project and say, oh, we've got a project and we're going to do co-design. Okay, we need to get people together and make it happen. Probably isn't the most effective way of doing it. But really, truly effective co-design and co-everything starts way before that. So it's the conversations and the consultations, the relationships you've built with people over the last year, 2 years, 3 years, 5 years, where you've actually been in the background talking about certain issues that can feed into some kind of project, whether it's a research project or something else. But even though you haven't necessarily sat down and said, okay, we're now going to co-design, you've kind of started that process through collaborative partnerships beforehand. And so then you can kind of get to a point of, look, we've been talking about this for 5 years. Why don't we do something about it? And at that point, you've already done the background work. You've essentially been working in a co-design type environment, and then you can build on that in a more formalized way.
Thank you. Everything that you have all just shared through that Q&A process sounds really hopeful for the research space, to know that there's this reflection and there's this drive to ensure that the voices that you are hearing, their input is being taken on board, and that their well-being is truly cared for in this space is great to hear. That's all the time we have. That went very quickly, as these Q&As tend to do. There's so much rich information coming through. So thank you to all of our speakers, Timothy, Sarah, and Zhao Ping. I'll now hand you over to Tish, who will be speaking about our next activity. Thank you.
Hi, everyone. Thanks so much, Prue, for that, and to our 3 speakers. Wow, what a rich conversation that was. That was just really, really interesting. So we're going to have this is your chance now to have some input, and a really important part of the session. So you're going to be put into breakout groups randomly. There'll be a facilitator from Carers New South Wales in the group, and they will share a template with you where they're going to jot down your ideas. But really, it's a discussion amongst yourselves and members of your group to think about what you've heard this afternoon and think from a carer's perspective, what are the pain points for carers in the use of these tools? And then what are some of the solutions to some of those things? And you've heard a bit of both, obviously, this afternoon. So it'd be really great if you have your chance to have your say now. And at the end, what we'd like to do is ask you to bring your most powerful idea from the discussion to share. So, and record that in the chat. So we'll give you a little prompt throughout, and Prue and I will pop into the groups. Please enjoy your time in the group, and feel free to contribute your fantastic thoughts to the activity. Thank you everyone, and thank you for that message up there on the screen. I assume that was one of the Carers New South Wales team that's popped that up. Thank you very much. Look, that was great. I don't know if you had as much interesting discussion in your groups as we did, but it was great. And what's remaining to do now is for someone from each group, and it can be the Carer New South Wales scribe that was diligently scribing down the thoughts, to just use the chat function to try and put what you think was your most powerful idea from your group discussion. Just one would be great. We've got obviously all of the data from there, all of the information from your discussion recorded on a template. But if each group could just put down their most powerful idea from that discussion, would be really, really good. Thank you. I can see some of them coming in now, which is fantastic. That's, yes, to challenge the assumptions. Thank you, Lucas. And we've got promoting carer wellbeing needs not just to be the goal of the ultimate use of data, but also central to the actual implementation of the measure. The measure should not add stresses, but promote understanding. Lovely. That's great. Thank you. Multimodal participation and dissemination of knowledge capture. Fantastic. And I'll just expand a little bit on Lucas's assumption, Lucas's point in there is that we were, in our group, we were talking about not assuming that we know or have predicted the outcome of a lot of things, but expanding to think about the voices that are not being heard and why they're not being heard, and ways that we can expand the types of instruments that we use to collect data, with sorts of things that were discussed there. We've got a lovely thought here: don't do research for research's sake. Inform carers what research is about, what the expected outcomes are, and following participation of carers by advising an outcome, show people the finished product. Lovely. That's a really very important a thought there, Mary. Thank you for from your group. Do we have any other group messages coming in? We'll watch those come in as we close now. And as I said, thank you to the facilitators from Carers New South Wales who diligently recorded all of our comments during those breakout sessions. Well, what remains to do is to just say thank you to everyone for participating this afternoon, and just reflect for a moment on just how much interesting information has been shared with us by such three incredible people who are working in the field and doing research in the field. I certainly have learned a lot this afternoon, and I think it's really opened my eyes, as I did yesterday for the session that I was involved in, really opened my eyes to new learnings. And I hope that those of you that are on the line this afternoon have felt the same way. We really have tried to crack open a few areas that are often not don't get enough focus. So we're hoping that they do share, share and expand everyone's understanding of the different areas of carers research. Thank you for participating. Thank you for staying till the end, those of you who have stayed. Thank you to our speakers. You've been amazing. Thank you to Prue for co-facilitating this session with me, and to the entire Carer Knowledge Exchange team and all of the support from Carers New South Wales, that the supporters that have made this a really useful afternoon. Thank you very much. Safe travels if you're traveling anywhere, and thank you very much. We will be sharing a lot of the learnings from this back with you via a communique. So if you know anyone who is interested, stay tuned, jump onto the Carer Knowledge Exchange website, and look out for more interesting activities that are coming up in the exchange. Thank you very much, everyone, and good afternoon.